Welcome back to The Verdict, a podcast brought to you by Milmick Insurance Company. As we celebrate our 50th anniversary, we continue to deliver clear insights on navigating the complex world of medical professional liability. Join us as we cut through the noise to bring you essential information, expert perspectives, and compelling discussions designed to help and protect you and your practice. Be sure to like and subscribe to our YouTube channel so you don't miss an episode. My guest today is my friend and colleague, Dr. Salvatore Volpe. Well, good afternoon, Dr. Volpe. I'm so excited to have you back as a guest on The Verdict. I actually can't even remember how many times we've had you on the podcast so far, but I'm going to guess and say maybe 4 or 5. And I just love the fact that you're a regular guest and you provide so much impactful information for physicians and healthcare providers throughout the state. So I'll just like to say on behalf of myself and all of Milmick, we're really grateful for all you do. And before we get started today, how are you?
Well, I'm well, thank you. And I do appreciate these sessions that we have together, Tammie, and it's an opportunity to share information that we both feel is very important for the members of Milmick. This is yet another important topic that I believe we're going to talk. They can't see me, but I'm wearing my Ferry Hawks cap, which is the local baseball team of Staten Island, trying to support. So
There
go
you
Ferry
go.
Hawks.
Go Fairy Hawks. So today we're going to talk about our topic today is really something that I'm really not at all familiar with. So I'm looking forward to hearing everything you have to say about the importance of utilizing social care networks. Can you maybe just start off with telling us and informing me what exactly is a social care network?
Sure. So I have to warn the listeners, there's a lot of information coming their way. We're going to have links and an opportunity for them to see some of the stuff in writing. So don't get overwhelmed, but let's begin. I want to start with this concept of social determinants of health. Many of you may have learned about it in medical school, maybe during your residency or sometime thereafter. Still not something that's very well known throughout the physician healthcare community in the United States and New York. But according to the Office of Disease Prevention and Health Promotion, social determinants of health are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affects a wide range of health, functioning, and quality of life outcomes and risks. This is such an amazing thing, and depending on the literature, it's been out there, and I'll say that Europeans and other countries have really absorbed this and built this into their systems, and it's something that now we're hoping to share. Social determinants of health can impact over 50% of health outcomes, which is greater than the impact of medications and traditional health intervention by healthcare providers and traditional health systems. And just take a moment to think about how wonderful it is. We have all these great health systems. We've got all these well-trained physicians. We got MRI machines. We got the latest technology. And yet it's these SDOH variables that can really make the biggest difference at the end when we look at the total span of one's life. So what are examples of SDOH, social determinants of health? Safe housing and transportation in neighborhoods, education, job opportunities and income, access to nutritious foods and physical activity opportunities, discrimination and violence, polluted air and water, language and literacy skills. Just to hammer this home again, you may have also read somewhere that your zip code has a greater influence on your health outcome than your DNA. Of course, there are exceptions, someone with cystic fibrosis, but in general, where you live, biggest impact. So SDOH contributes to a wide degree of health disparities and inequities. So for example, people who don't have access to grocery stores with healthy foods are less likely, obviously, to get good nutrition. This raises their risk of issues such as heart disease, diabetes, and obesity. And this will ultimately lower their life expectancy compared to those people who do have access to healthy foods. Again, nothing novel that I'm describing, but something that really needs to be thought about. And until now, we really couldn't do anything about it. According to the Federal Healthy People 2030 Initiative, just promoting healthy choices just promoting healthy choices won't eliminate these and other health disparities. Instead, public health organizations and their partners in sectors like education, transportation, and housing need to take action to improve the conditions of these people. Now, this is where the social care networks, or SCNs, I'll use them both interchangeably, come into play, because they are only for certain individuals in managed Medicaid. So it's not for everyone. It won't be for all your patients, and it's not for all your Medicaid patients. It's a subset of managed Medicaid patients. While SDOH are variables on a community level, think of health risk social needs, or HRSNs, as reflecting the specific gaps experienced on an individual level. Now, an example of this could be the lack of a stable or affordable housing. So you may have heard of people who are couch surfing. They literally don't have a regular place to live, and they're bouncing around from location to location. The lack of access to healthy food, we mentioned, the lack of access to transportation, financial strain on employment, and certainly if there are issues with personal safety. Here are some more key terms. Social care networks tie together multiple entities which have not traditionally worked together for many reasons, not the least of which was the lack of an integrated system. This system facilitates HRSN surveys, so we can identify what the individual needs, navigating those in need to the appropriate service provider, coordinating the compensation for the services provided, and providing a global view on the impact that these services will have on the health of each individual. So just think, this one system now identifies a need, permits a referral to this service provider, gets them the compensation, and then we can look at it and say, what difference have we made after all is said and done? Social care networks are comprised of HRSN service providers, Medicaid managed care organizations, also known as MCOs, healthcare providers, and other organizations that contract with the SCN lead entity, which may be reimbursed for services authorized by this new Medicaid waiver. SCN lead entities are the organizations with expertise in supporting New York Medicaid members, a deep understanding of their region, and an ability to coordinate this ecosystem of partners. In New York State, we have 9 SCN lead entities in 11 regions. And as part of full disclosure, I am the chief medical officer of one of these SCNs. So you know my background and where I'm coming from. HRSN, health risk social needs service providers, these are organizations that provide the services to meet the individual's needs around food, housing, transportation, etc. These can include local community-based organizations, nonprofit organizations, government entities, the healthcare providers, and private sector entities. They will contract with the SCN to deliver a specific set of services, again, to the qualified Medicaid managed care members, and they'll be reimbursed. Again, this is something we never had before. Healthcare providers these are, again, things that we know. These are the organizations that provide the little healthcare services. They can be the primary care providers, the behavioral health specialists, federally qualified health centers, also known as FQHCs, health homes, health systems, hospital systems, etc. The healthcare providers will be key ecosystem partners in the SCN program. The idea is to better integrate healthcare and social care through a stakeholder convening and a common data and IT layer. Most of us may know of community-based organizations in our neighborhoods, food pantries, homeless shelters, but we never really had a system, one, to coordinate referring our patients to them and getting follow-up on what happened after that referral. So that was a lot to digest, but we're going to give you a lot of links. We'll give you an opportunity to review these terms. And now we're going to talk about some of the services that are available.
Great. Well, thank you for all that. And thank you specifically for explaining what HRSN stands for, because I wasn't sure. I know. You made me think back, and I've told this story to a couple other people because it was so impactful to me about zip codes and social determinants of health. But I remember, I'm going to say it was 2016 or 2017. I was at a dinner at the Erie County Medical Society, and Dr. Willie Underwood was talking about certain zip codes in Buffalo and all like the diseases and the lack of medical care these people were suffering from. And I thought it was the first time I heard that, and I was like, wow, it was so impactful because I had no idea, right? And I feel like now where we are right now in 2025, it's so mainstream, right? Like physicians in the community are thinking about these issues.
Very true. And I think one of the things that, I know in talking to our peers, the idea is, if I survey someone and I can't provide them with access to the service, um, how good is that? Well, it's good to know what's going on in the community, because then ultimately a project like this could be launched. So it's not fruitless to do the survey, but now not only do we assess the need, but maybe we can get them the services that they require. So there are like four major categories of services that we already discussed: nutrition, housing, transportation, and the social care management. I'm just going to focus on two because, again, it's a lot of information. So when you think about the nutrition side, so there's counseling, which we do already, and we may have a dietitian and nutritionist who does that. There's education. Again, we might do it, or someone in our office. But now the new spin on this: medically tailored meals. Think of your congestive heart failure patients who have been repeatedly admitted, and they just can't seem to get off that downward spiral. Wouldn't it be wonderful if you just get them off that track, stabilize them, in some cases for up to 6 months, while you are working on getting them the right groceries, teaching them how to shop, teaching them how to cook. We also provide them literally with cooking supplies, pots and pans, microwaves, even refrigerators if necessary. So it's not just I want you to do something conversation. It's I want you to consider doing something. Let's work as a team. And I know you don't have the resources. Let me provide you with the resources. Let me have someone literally go into the supermarket with X number of patients and just teach them how to avoid those aisles, which have all the yummy, high calorie, high fat, high salt, and stick on the outside, which is traditionally where the fruits and veggies are located. So it seems simple and fundamental, but we never had the resources to do it. And then on the housing side, providing, just making things more accessible. You have individuals with either physical disabilities or other disabilities, maybe putting in a ramp, changing how the steps are set up, changing how in the home, maybe we need to put a couple of rails to make it safer. Remediation. So we talked about all the different things we can do. Well, for people with respiratory issues, and maybe even without, wouldn't it be wonderful if we could take care of that mold and the pests that are accumulated in there? Think of the effect it'll have on their respiratory system, plus their overall health. This leads into the asthma remediation, where not only do we take care of the mold and pests, but now we can provide them with coverings for their beds so they don't have to deal with the bed mites as much. Everything's kind of covered, right? We can provide them with vacuum cleaners with HEPA filters. A lot of houses may have carpeting or rugs, which over time accumulate dust and everything else. If we could give them a vacuum cleaner just to keep it clean, that will help reduce the respiratory burden on the patient. Air conditioners. We've gone through this heat wave, and I know it's not going to stop too soon. Well, you just imagine a person who is compromised medically not being able to reduce the temperature in their apartment or home to something that's livable, and or living in an 85 to 95 degree environment, and then air purifiers in general, HEPA filters. So those are just some of the services. And again, promise you, in the links, subsequently, you'll see all these great things. But I just want to remind everybody, it's a new age. Not only can you identify the problem, but you can provide the relief. Let's see. So what kind of patients would qualify? Because remember I told you, it's not everyone. It's not everyone in Medicaid. And even on the managed Medicaid, there's some populations where there's a focus. So one population are members with either substance use disorder or serious mental illness. Members with either intellectual or developmental disabilities. Super key here, next, pregnant and postpartum persons. We will be able to intervene before a person's born. Just imagine for the pediatricians in the audience, for the OBs in the audience, and family medicine in the audience, and anyone else that has known a pregnant woman or newborn. What a difference it would make if we can make that gestational period safer for both of them. Members who have recently been released from incarceration and have chronic health conditions. Children under the age of 18 are covered if they have a chronic health condition. So think of the poor child with asthma or even type 1 diabetes. Frequent health users. So these are individuals who have been in the emergency room X number of times per year or hospitalized X number of times per year. These are considered people who are high utilizers in need of additional intervention. And people enrolled in a health home. For those of you who don't know what a health home is, because they didn't teach me what a health home was when I was a medical student or a resident. So a health home is not a physical location. So just it's home in air quotes. But it's a program designed to improve care coordination and management for those individuals with chronic health conditions or mental health needs that are enrolled in Medicaid. You may not have a lot of patients in health homes, but it's something that you should be aware of. And for those of you who obviously do have health home patients, just think of this as yet another amazing set of resources.
Great. Well, thank you for all that information. It is a lot of information. And as you said, we'll be providing some links with this podcast. And I just also wanted to let our listeners know that before we started recording, we did talk about creating a blog to coincide with this podcast. So be on the lookout for that. It will have a lot of graphics and all the information that we're talking about today. So we don't want any of our listeners or our insureds to miss any of this really critical information. Now, Dr. Volpe, how does understanding the social care networks available to their patients benefit healthcare providers and also the care that they deliver?
Well, Tammie, we spoke about some of the benefits, right? Services. And something that's important is this idea of an attestation. And again, I'm full disclosure kind of person. When I heard attestation, my brain flipped it into the word authorization and pre-authorization. And for many physicians, those are words that do not make us feel all warm and fuzzy, but tend to ignite some sort of negative feeling about work that just seems to be imposed upon us by a managed care organization. This is nothing like that. Please do not think of it that way. This is an opportunity for the healthcare providers to support their members in accessing enhanced health-related social needs services just by confirming their eligibility with these social care navigators. So you'll be getting phone calls, perhaps. You'll get a fax. You'll get the form that lists the different categories in which a person could qualify. You're encouraged to call the social care navigator if needed, because we want you to feel comfortable attesting that a person can qualify. So the social care navigators, they tend to be community health workers, another profession that we will be working with more and more as the years go on, because they fill a need that is very intense, and they work in offices, hospitals, they do house calls. They are an incredible profession that we need to respect and utilize. So a social care navigator might request a provider to attest in certain situations, such as when the eligibility criteria are not available in the member's managed care organization data. So, the social care network navigator asks the questions of the patient. They do the survey. They look through some data that they're getting from the health insurance company. Remember, we were talking about high utilizers, and maybe there are gaps for some reason from the insurance company. So they'll ask you, was this patient in the hospital, X number of times over the past 12 months? Because remember, just as patients can switch doctors, they often switch insurance companies. So insurance company A may have only had the patient for the past 30 days and is not aware of the previous 11 months multiple admissions. So we may not get that information from the current covering managed care organization. So providers may be asked to attest to the presence of certain clinical criteria, a diagnosis of chronic conditions. We talked about mental health, pregnancy, postpartum status, a child's risk of malnutrition, history of low birth weight, etc. So there's many opportunities for us to intervene without it being burdensome. And again, there are individuals at the social care network who can answer your questions. So if you feel uncomfortable initially, or just you've never seen this before and you haven't done so, call in, have the discussion. You will be surprised at how relatively easy it is, and you will be getting amazing feedback from your patients who have had food insecurity, housing insecurity, etc. Especially just think of that pregnant mom who can now finally get some good food for her and her unborn child.
Great, thanks for that, Dr. Volpe. And I would imagine with all these services and the good nutrition and the housing, I would imagine that you see improved patient outcomes using social care networks, right?
That you're absolutely right, Tammie. I'm sorry, I think I cut you off, but you're absolutely right. That is the goal. Remember, in New York State, this has only been running since January, and I know it's August, so you say, wow, 8 months, they must have a lot of data. Well, things were slow moving. It had to do a lot of operational issues. So it is not until we enroll a critical number of patients with different conditions that we will see it. And I personally believe that we will. I think one of the categories that we will see sooner than later, I hope, is asthma, because we know that's very acute and changes can happen rapidly. And you just need to go from someone that has a burden of X in terms of allergens in their environment, bump it up to X+1, and that's what tips them into needing to go to the hospital. So I think those individuals will see a difference. Reduction in myocardial infarctions, that's probably not going to happen as fast. Congestive heart failure. There was a quick story I like to share. I went to MIT, and we were not as a schooling, but it was a part of a educational exercise without a degree associated with it. So I went to MIT, and this really intelligent person was giving us a presentation on a woman, middle-aged woman, who had recently lost her husband. And starting 2 to 3 months after she lost her husband, she was being admitted to the hospital every 30 to 45 days in congestive heart failure. And these multiple visit patients are probably not as complicated as we think they are, but it's because we're not asking the right questions. So it's as complicated as it is until we ask the right question. So she's admitted multiple times, and it's not until like 2 to 4 months later that probably some well-meaning medical student walks up, sits by the patient, and she starts asking the patient some questions. And she talks about, the recent loss of the spouse. Now it's almost 6 months later. And what do you do? How do you live? So I know I am paraphrasing a paraphrase. So the way the story goes, and I don't think it's apocryphal, is the woman is now down to 1 income. There wasn't much Social Security benefit to augment what she was getting. So what she did was she would have 2 hot dogs for breakfast, 2 for lunch, maybe 3 if she was really hungry, and then 3 plus for dinner, with or without a bun. And as you know, mustard and ketchup, it's got its own salt burden, let alone the hot dog. And not surprisingly, after X number of weeks on this very high sodium diet, she would tip into congestive heart failure. They throw more diuretics at her, blah, blah, blah. But no one asked her about her diet. And maybe if they did, they didn't have anything they could do for her, right? But thanks to that medical student, they were able to do some sort of intervention. But now, because of this SCN, just imagine what's different now. We can get her medically tailored meals. We can figure out how to plug her into the right food pantry. Because remember, these meals aren't forever. They're usually for X number of weeks or months. Let's teach her, let's, for argument's sake, again, I'm not a chef, but I vaguely recall that if I boiled the hot dog before I broil it, one, it probably doesn't taste as good. But if I boil it first, I can get a lot of the sodium out of it. And I don't know if it's 5% or 30%, but definitely I can reduce the salt burden. And if she has a hankering for hot dogs, maybe that's something they could say. Obviously, you can't have it 3 times a day, let alone once a day. But whenever you're allowed to do it, maybe this is a safer way to prepare. And again, maybe look for low sodium options. So I bring that up because it's just an amazing thing, and it's an opportunity for us to intervene because of this accusation.
Yeah, that's a great story, and I'm glad that woman has made some changes to her diet. And I realized she probably couldn't she could only afford some hot dogs, but maybe she also thought that, hey, I'm going to do that all protein thing. I'm going to
Yeah,
eat protein, right? And maybe she thought she was doing well for herself and didn't realize the
absolutely.
salt, because people don't really know about all these nutritional components of food. And I was also going to mention, so it might take some time to, figure out if there's any changes in congestive heart failure or any of these other, serious chronic conditions. But I would imagine in this person specifically, you might notice like a decrease in cholesterol, or maybe some of the patients that are eating towards the outside of the supermarket and not the inside of the supermarket, they might have a drop in blood glucose or something. So you might see that quicker than some of the other major illnesses, right?
Absolutely agree with you. So we will probably start seeing some lab value changes. The fasting glucose will hopefully drop. Hemoglobin A1Cs, it'll take a couple of months, but we'll see it. And then again, depending on, these people who are maybe, let's say, couch surfing, if we can get them into more stabilized housing, they might be better able to take care of themselves, because maybe they don't have a place to keep all their meds, so they don't take their meds every day, for argument's sake. So there's a lot of reasons why people are multiple visit patients. It is multifactorial, and the key thing is, as William Osler, I believe he was a Canadian, but I think he's the father of North American medicine. He said you can get the diagnosis on a patient 90% of the time, pre-CAT scan MRI, just by talking to the patient. We tend to cut people off at 14 seconds or less. But if we just listen to them, like that young medical student did, she just listened to the patient. And she got an answer that no one really expected. They thought she just wasn't taking her Lasix. It wasn't that. She was taking Lasix and potassium and God knows whatever they kept throwing at her, the Bumex and all sorts of cool drugs. So yeah, I'm looking forward to longitudinally start to see, as you pointed out, let's see what's going on with the lab results. Let's go, even blood pressure. Super sensitive. Many people are super sensitive to sodium intake. Maybe if that sodium load gets reduced, we can start seeing drops in hypertension. And a program that we ran with the New York City Department of Health is where we gave out to individuals home blood pressure monitoring devices. And just a reminder of what happens when you binge on those hot dogs the night before, what it does to your blood pressure, can kind of remind you that, maybe I gotta back off a little bit. And I know Volpe told me to drink more water, so I guess I better do it today. Again, it's not a one and done. We're looking at a lifestyle change. And I really believe that this is the opportunity, because we're not gonna get too many. You can't do anything about a horrible plague like COVID that snaps right through and takes you X number of months to create a vaccine. But these are things that we can intervene early. And just the idea of intervening early is just amazing to me.
Yeah. I'm really excited to see what happens, and I'll look forward to seeing some studies. Hopefully, you will share them with us. Now we're going to change direction just a little bit because we are a medical liability insurance company. So from a medical liability perspective, what new challenges or considerations do physicians face when integrating their practice with these broader social care networks?
So I talked about the attestations. You're not going to see that many, but it's something that we should consider wanting and needing to do. So physicians should treat the social care network team the same way you treat any other members of the team, the same way you'd be thinking about a subspecialist in cardiology, pulmonary, rheumatology, etc. They are part of the team. They are a resource. You will work together. You need to connect with them. Clinicians should consider these resources as options in the management of their patients, not as something that maybe if you survey the patient, they may not tell you, because remember, if you didn't ask about the hot dogs, you didn't know about it. The health risk social health needs assessment is only 12 questions, and it covers a wide gamut of variables. And people are encouraged to spend a couple of minutes doing it. It's not a 30-second checkoff list. It requires a conversation, requires a certain amount of trust. It talks about feeling safe at home, whether you're worried about being abused verbally or physically. That's not something you do in a 2-second checkoff box. So it takes time to ask people. But if we can intervene there, again, downstream benefits for that patient and the other people in their family. So an example is, you prescribe medications and lifestyle changes for the patient with hypertension, diabetes, and CHF. And but wouldn't it be wonderful if we could add that nutritional counseling, the medically tailored meal, food prescriptions, the fresh produce and non-perishable groceries, the cooking supplies, the asthmatics, again, not just giving them an inhaler, but teaching their caregivers how to work with it, doing that home remediation, those air conditioners that we spoke about, protecting bedding covers, vacuums with HEPA filters, etc. So these are all the things we can do. So from a liability point of view, just do not consider them. If possible, please consider it.
Okay, and that sounds like an appropriate plan, and also probably documentation too, right? So if you're utilizing any of these social care networks, and let's say you have a conversation with somebody in housing or somebody who's doing the food prescription, it would be very the physician should probably document that in the record, right?
You are spot on, as always. So how are these surveys done? Well, providers, at least in our community, many of our providers are doing them themselves. So in one situation, it's built right into the EHR. So for those of us who are patient-centered medical homes, we're familiar with doing SDOH surveys. Those are built into the EHR. Sometimes we had a resource for them. Most of the time we didn't, but it was in the EHR, it was documented, and we could follow it up. These HRSNs, similar topics covered, but they're very specific. If they're hardwired into your EHR, that's great, because now you have a documentation of what you asked. They're coded with something called LOINC codes, LOINC, so it's easier for the Health Information Exchange to follow this and then pass it on to us. If it's not built into your EHR, your local HIEs, Health Information Exchanges, may have a portal that you could just log into, and it will let you do these surveys. Many of them will print out a PDF because, as you pointed out, Tammie, super important. You want this in your record that you asked for it, and that you can follow up on what happened after you asked for it. So we have EHRs that can do it, and we have portals that can do it. But to your point, super important, do not treat it as some silo. It has to be part of your care plan and follow-up. Thank you for bringing that up.
And thank you for providing that information. Now, looking ahead, how do you see the evolution of social care networks impacting the standard of care or even the patient-physician relationship? Let's say like over the next 5 to 10 years.
So I believe over the next 5 to 10 years, if we are successful, we're going to finally show not just a medical benefit and health outcomes and improved quality of life, but also financial impact. How many families could we educate to better manage their children's asthma if we avoid one admission? How many groceries, meals, healthy food preparation, and shopping classes could we provide if we avoid one CHF, DKA, or MI admission? How many lost days of employment could be saved, not just for the patient, but of the parent or other caregiver? So there's a lot of financial impacts potentially ahead of us. And, having spoken about like medication reduction, access to people in the ED, opening up the ED because there'll be less people going for preventable reasons. So that should reduce the burden on the emergency rooms, may even reduce the burden on some specialist offices because people may not need to go as frequently because they're better controlled. And again, I think it'll improve access to care as well as having a financial impact. Historically, the US has focused on acute care and has outcomes related to lifespan and maternal child mortality that are significantly worse than many other countries with fewer resources. It's counterintuitive. Wealthiest country, best tech, access to all the meds, and yet we don't live as long as other individuals. And we have moms and babies dying at a higher rate than other countries. So I believe this, holistic approach will move the interventions, as I said before, rather excitedly, I might say, literally before birth in some cases. And by improving the quality of life of patients, this will no doubt enhance the patient-physician relationship. We've all had patients where we were able to make one little intervention, and they're not always life-saving interventions, but maybe we got them a connection with someone who could help a parent at home, or a new subspecialist as the previous subspecialist retired. These are potentially easy things to do that don't impact us individually, perhaps as a physician, but makes a big difference in the life of that patient. And now just think about, as I said, the mom who could feed herself and her unborn child, or her postpartum child, and not having to watch her kid wheezing all night before bringing them to the ED. So these are amazing things. And, hopefully, looking at that 5 to 10 year mark, hopefully less than 5, these interventions are going to be expanded to all, independent of life insurance. Because, this is a managed Medicaid subset. It would be wonderful if we can show the health benefits, but also the financial benefits that, the managed care organizations say, it does make sense to allocate a certain amount of money here. Because in the end, it's either a break even or a win. And it's not an extra cost center. So keep your fingers crossed, and let's hope.
Fingers crossed, Dr. Volpe, because it seems like a wonderful program in my opinion. Before we say goodbye, do you have any final thoughts for our listeners?
No, I apologize for throwing a lot at you. But as I said, there'll be a lot of stuff in writing that you can review. I do encourage you, if you don't know who your social care network is, we'll include a link so you could see where they are. They have probably begun reaching out to you. I wouldn't be surprised if your patients were reaching out to you, because managed care organizations have been sending correspondence out to their patients saying, you may qualify for something. Contact Dr. Volpe, and he'll let you know what's going on. But as you know, not everyone reads all their snail mail for many reasons. And sometimes they just need to be reinforced. And you need to prepare yourselves, because you will be getting calls from the patients asking to see if they qualify, calls from the social care networks, from these navigators asking for your help. So I think if you look at the resources that we're sharing with you, you could be better prepared. And I believe the satisfaction is great. I know like in our own office, the staff, whenever they made just a little more, can go home and feel they made a difference, right? We want our people to be healthier, and I think we like to feel that we made a difference. So
For
that's
sure.
my take.
For sure. We all want everybody to feel healthy and we all want to make a difference, right? So fingers crossed for social care networks for the future. And I thank you for joining us today.
You're welcome, and I'm so appreciative of the time Milmick gives me to spend with you and discuss these topics.
Thanks. And listeners, Dr. Volpe will be back soon, I promise.
Looking forward to it.
And that's the verdict on social care networks in New York. As Dr. Volpe mentioned throughout the podcast, we will provide links to a number of resources in the notes for this podcast. Our blog providing further information on this topic will be published on milmick.com in September. Follow us on Facebook, LinkedIn, Instagram, X, and YouTube to stay connected. This podcast is for general purposes only and should not be construed as medical, dental, or legal advice. This podcast is not comprehensive and does not cover all possible factual circumstances. Because the facts applicable to your situation may vary, or the laws applicable in your jurisdiction may differ, please contact your attorney or other professional advisors for any questions related to legal, medical, dental, or professional obligations, the applicable state or federal laws, or other professional questions.